Hello everyone, today I'll be discussing about TAVR or Transcatheter Valve Replacements. I'm Dr. Amit Sharma, Director and Head Cardiology, Paras Hospitals, Gurgaon. Common myths and facts about TAVRs. TAVR is transcatheter valve replacement without the need for any open heart surgery, no scars, no stitches, no need for any general anesthesia. It is done purely under conscious sedation. You've heard it right. 15 years ago, if somebody had said that you can do a valve replacement without the need for open heart surgery, people would have laughed at it. But now this is what the TAVR valve looks like. It is either a balloon expandable valve or a self-expanding valve. This is a balloon expandable valve. You can see this is a porcine valve made from pig skin, or it could be a bovine valve, which could be made also from a cow's skin, cow's pericardium. Now, question is, what is the combination? What is the comparison between TAVR and open heart surgery? Open heart surgery or SAVR, surgical aortic valve replacement, has been there in the pipeline for quite some time. It involves opening of the heart and cutting the aortic valve and putting a new valve. The new valve could be a mechanical valve or it could be a bioprosthetic valve. But elderly patients who have got high comorbidities, hypertensive, diabetic, elderly population, they do not withstand this procedure well. So in 2001, Dr. Alan Crebier, a French cardiologist, invented this procedure for which he won a Nobel Prize. This is called as transcatheter valve replacement. From 2001, it has come a long way. In India, we did our first case in 2015, and from there on, we've been going strong. Earlier, we used to do it with general anesthesia. Now we can do it without the need for any general anesthesia. No, only conscious sedation required. The patient goes home the next day, and sometimes the patient can go home within 24 to 48 hours. Comparison between open heart surgery versus TAVR. Open heart surgery requires or open incision of the chest. Recovery is much more prolonged. Risk of stroke is much higher. In case of open heart surgery, the requirement of prolonged ventilation is there. Requirement of ventilator associated pneumonia, ventilator associated complications are there. And obviously the general morbidities associated with the bypass operation is very prevalent, especially in elderly populations who cannot tolerate such procedures. So in such cases, TAVR is a boon for elderly patients who are more than 65 years of age, who have multiple comorbidities. In such patients, TAVR is a boon. Even in an intermediate risk patient or a low risk patient after the age of 65, TAVR is a very, very effective alternative to surgery. Younger patients somehow do not fare well with TAVR. Younger patients, very young patients, you still have surgical options available, especially for a bicuspid valve, wherein instead of having 3 cusps, you have 2 cusps. That is available. But suitability for TAVR, anybody who's above the age of 65 has got a severe aortic stenosis. Aortic valve is the biggest valve of the body. If the aortic valve area narrows down from 4 to 6 centimeters to a 0.4 or 0.5 centimeter, that is called as critical aortic stenosis. How you diagnose it? You diagnose it with the help of a 2D echocardiography. Normally the pressure gradients, if the pressure gradients are more, the mean pressure gradients is more than 60, it is severe TAVR. If the mean pressure gradients of more than 40, it is moderate. And if it is less than 30, it is normal. So in such patients, if you have aortic valve gradients which are high, aortic valve area which is narrow, such patients are an ideal candidate for TAVR surgeries. And TAVR, there is the risk of stroke is 3 times less. The risk of infection, risk of ventilator associated pneumonia is next to negligible. The patient walks after the next 24 hours, and there are various routes to do TAVR. We can either do TAVR through the groin, we can do through the axillary approach, we can do through the carotid approach. So the procedure itself takes about 30 to 35 minutes. But in such cases, a good heart planning is required by the heart cath team. Heart team comprises of a cardiac surgeon, a cardiologist, cardiac anesthetist, imaging experts who are there. So cardiology imaging experts which are there. So it is and plus a radiologist. So in such cases, we do a CT scan of the legs to see the size of the arteries, whether they can go from the legs. Then we do a CT aortogram to check for the tortuosity and to decide the size of the annulus and the size of the valve. So CT is mandatory in addition to the 2D echocardiography.